First, we will learn anatomy of the spine and skull. So, what is a vertebral segment? So, a single complete vertebral bone with associated articular process and laminae. So, a single complete vertebral bone with its associated articular process. So, what are articular process? Spinous process as well as transverse process and laminae. So, these are the parts of the vertebral segment. Whenever you want to code for vertebral segment, you need to understand vertebral body also. So here vertebral body is different, vertebral segment is different. Vertebral body is without articular process, including spinous process as well as transverse process. So vertebral segment is with articular process, including spinous process as well as transverse process. So basically vertebral body without articular process, vertebral segment with articular process. And what are these articular process? Transverse process as well as spinous process, simple. So what is vertebral interspace? So which is simple. So vertebral interspace is the non-bony compartment between two adjacent vertebral bodies, which contains intervertebral disc. And also the parts of intervertebral disc are nucleus pulposus, annulus fibrosus and two cartilaginous end plates, which consists of intervertebral disc. So what is vertebral interspace? Vertebral interspace is the non-bony compartment between two adjacent vertebral bodies. So this is the most important interview question for you. If you go to interview, they will ask you what is the difference between vertebral segment and vertebral interspace. Okay. So vertebral interspace is the non-bony compartment between two vertebral bodies. Vertebral segment is the combination of vertebral bone with its articular process. This is very important for interviews. Next, what is lamina? So the flat plate of bone forming the back wall of the spine canal at each vertebral level. So basically this is the flat bone of the bone on the back side of the spine. Most of the time using the lamina we have multiple procedures like hemilaminectomy as well as laminectomy or laminotomy, which we will see soon. Sometimes patient will remove this flat plate. So removal of that flat plate is called as laminectomy. Sometimes patient will remove only portion of this flat plate. So that time we will call it as hemilaminectomy or laminotomy. So just now we have discussed spinous process, correct? So what is spinous process here? The bony projection extending posteriorly from the vertebra palpable along the midline of the back. So for example, if you want to identify this spinous process, you need to keep your finger on the back side of your bone or back side of your body. That time you can find this projection, which is the spinous process. So what is pedicule? So the short thick column of bone connecting the vertebral body to the posterior elements on the each side. Okay, so here they are telling each side, means in our spine we have two pedicules. So pedicule is a short thick column of bone connecting between vertebral body to the posterior element on each side. So basically this pedicule is the connecting medium between vertebral body and posterior elements. So if anyone looking for medical coding jobs in UAE, USA and India, please join in our WhatsApp group. Group link is in the description of this video. And also if anyone looking for same day surgery coding training, SCC coding training, please send WhatsApp message to 707-526-3939. Next, facet joint. Other name for facet joint is zygapophyseal joint. So which is the joint between two vertebrae. So the paired synovial joint between articular process of adjacent vertebra that guide spinal motion. Okay. So facet joint is the joint between two articular process of the adjacent vertebra basically. So we have most of the time you can hear this word during facet joint injections. Okay. The documentation contains facet joint or zygapophyseal joint, both are same. You can use the same CPT codes, which we will learn soon. Next, we have pars interarticularis. Basically, you will see this word in the operative reports. So what is this pars interarticularis? The narrow bridge of bone between the superior and inferior articular facets of a vertebra. Most common fracture site in spondylolysis. Okay, so you will see this fracture or pars interarticularis fracture in spondylolysis. So this is the superior articularis and this is the inferior facet joint. Okay. So the pars interarticularis is a small segment of bone connecting the superior and inferior articular facets of the vertebra. Okay. So this is the vertebra. Okay. So these are the joints between two vertebrae is called as facet joint, correct? So this is the pars interarticularis. So next, what is a foramen? So other name for this foramen is neural foramen or intervertebral foramen. Okay. So the bony opening on each side of the spine through which a nerve root exits the spinal canal is called as foramen. Okay. So this word also very important in live coding. So you will see it as foraminotomy. So fish will create incision on this foramen. Okay. Or neural foramen or intervertebral foramen. Okay. So what is foramen? The bony opening on each side of the spine through which a nerve root exits the spinal canal. Next one, lateral recess. So most of the time you will see this word during stenosis procedures or spinal stenosis. So the lateral portion of the spinal canal where a nerve root travels before entering the foramen. A common site of stenosis from facet hypertrophy or ligamentum flavum thickening. Okay. So it is the lateral recess because it is the lateral portion of the spinal canal. So that's why they have mentioned it as lateral recess. Next one, ligamentum flavum. So most of the time this ligamentum flavum is on the back side of the spine. If you see this ligamentum flavum, you need to understand that patient is performing procedure on the back portion of the spine. Or you need to think like that patient is performing procedure on posterior approach. So the thick yellow elastic ligament connecting the laminae of adjacent vertebrae along the length of the spinal canal. Hypertrophy is a leading cause of central and lateral recess stenosis. Okay. So this is the ligamentum flavum. So basically this ligamentum flavum presents in between laminae of two adjacent vertebrae. Ligamentum flavum is not a bony structure. Next we will learn spine neural contents. So what is the spinal cord? So the cylindrical bundle of nerve tissue extending from the brain stem to roughly the L1 to L2 level, where it tapers into conus medullaris, which is the spinal cord. So what is cauda equina? So the bundle of lumbar and sacral nerve roots extending below the conus medullaris within the thecal sac is called as cauda equina. So this is very important, thecal sac or dural sac. What is thecal sac? So the membranous tube of dura mater enclosing the spinal cord, cauda equina and cerebrospinal fluid, a central anatomical structure, not an interspace. So basically the covering of spinal cord, cauda equina and cerebrospinal fluid is the thecal sac. Other name for thecal sac is dural sac, which is not a interspace. Next, nerve root. So this word is very important if you want to code for decompressions. If you want to code for decompression, we need to check for nerve root in the operative report. An individual spinal nerve as it exits the thecal sac and travels through the lateral recess foramen to its destination. Okay. Basically nerve root is the individual spinal nerve as it exits the thecal sac and travels through the lateral recess and foramen to its destination. So basically nerve roots are the starting point of the spinal nerve. What is dura mater? The outermost, fibrous and toughest of the three meninges surrounding the brain and spinal cord. Epidural space. So this is very important for coding. Most of the time we have epidural steroid injections. So the potential space outside the dura mater inside the spinal canal. So most commonly It is the site of epidural injections and percutaneous decompression access. So most of the time we will see it as epidural steroid injections during pain management coding. So that time this is the epidural space. Space outside the dura mater, inside the spinal canal. So basically in between dura mater and spinal canal. What is nucleus pulposus? The soft gel-like inner core of the intervertebral disc. So basically middle of the intervertebral disc is called as nucleus pulposus. Surrounding this nucleus pulposus we have annulus fibrosus. Next we will see skull and brain. Okay. So what are cranial fossae? So there are three depressions in the floor of the skull that cradle the brain, anterior, middle and posterior. Okay, so basically fossa means depressions on the floor of the skull. So basically think like that, floor of the skull divides into three parts. Okay, anterior, middle and posterior. These three parts combinedly call it as cranial fossae. So next, what is supratentorial? So above the tentorium cerebelli, the region containing the cerebral hemisphere is called as supratentorial, or above the tentorium, or above the tentorium cerebelli is called as supratentorial. Next we have infratentorial, which is on the posterior fossa. So we have three fossa, correct? Anterior, middle and posterior fossa. So we will see infratentorial in the posterior fossa, which is the middle part of the floor of the skull. So infratentorial, which we will see mostly on the posterior fossa. Okay, so we have anterior, middle and posterior, correct? So infratentorial is on the below the tentorium cerebelli and which is on the posterior fossa. So below the tentorium cerebelli. Next, cerebello-pontine angle. Okay, so the space between cerebellum and the pons, a frequent site of vestibular schwannomas and meningiomas. So basically schwannoma and meningiomas are the tumors of the brain. Okay, which is the space between cerebellum and the pons. Next, cribriform plate. So the perforated roof of the ethmoid sinus through which the olfactory nerve passes into the brain. So you will see this word cella tarsica or paracellular area. The bony saddle in the sphenoid bone housing the pituitary gland. The paracellular area surrounds it. So which is the cella tarsica. Sometimes in the operative report we will see clivus, the sloped bony surface at the central skull base in front of the brain stem is called as clivus. Foramen magnum. So the large opening at the base of the skull where the brainstem joins the spinal cord. Okay. So next we have cavernous sinus, a venous chamber on each side of the cella containing the carotid artery and several cranial nerves. Next we will find jugular foramen, a skull base opening transforming the jugular vein and several cranial nerves, a common site for paragangliomas. This is also one type of brain tumors. Okay, so this is the jugular foramen. Now we will see common procedures and techniques we will encounter in the neurosurgery coding. So laminectomy, as we have discussed previously, so the surgical removal of lamina to access the spinal canal or relieve pressure on neural elements. Most of the time you will see laminectomy during the decompression procedures, where physician will remove this lamina in order to reduce pressure on the neural element. Next, laminectomy. Other name for laminotomy. Other name for laminotomy is hemilaminectomy. So laminectomy means complete removal of the lamina. So laminotomy is partial removal of the lamina. So removal of portion of the lamina, generally on one side to access single nerve root or disc. Next, facetectomy. So removal of part or all of the facet joint. So partial facetectomy is commonly performed with foraminotomy for nerve root decompression. Complete facetectomy is typically performed only with fusion. Okay. So most of the time physician will perform partial facetectomy with nerve root decompressions. If the documentation contains complete facetectomy, we need to check for whether physician is performing any fusion or not. Okay. Next, foraminotomy. surgical enlargement of the neural foramen to relieve pressure on an existing nerve root. Atomy means basically incision. Foraminotomy means incision on the foramen to enlargement of neural foramen to relieve pressure on the existing nerve root. So discectomy. So removal of all or part of the an intervertebral disc. Next, carpectomy. So vertebral body resection. Partial or complete removal of a vertebral body often performed for tumor infection or fracture. So as you remember, previously we have learned like vertebral body is different, vertebral segment is different, correct? So carpectomy is complete removal of the vertebral body, not the vertebral segment. That is very important. Next we have osteotomy. So a planned cut and removal of bone to correct deformity. So most of the time in the spinal procedures you will see osteotomy what? So basically patient will perform cut on the bone or removal of bone to correct deformity. Spinal osteotomy are described by anatomic region and column involvement. Single column or 3 columns osteotomy. Okay. Also, if anyone looking for jobs in UAE, USA and India, please join in our WhatsApp group. Group link is the description of this video. So, and also if you are looking for same-day surgery coding training or SCC coding training, please send WhatsApp message to 707-526-3939. Next, kyphectomy. Okay, so basically this kyphectomy is useful for kyphosis. So what is kyphectomy? Removal only here also. So circumferential resection of one or more vertebral segment, body and posterior means to correct severe kyphotic deformity. For kyphosis, physician will perform kyphectomy. Okay. Next, we will see few important definitions related to stabilization and grafting. Okay. So arthrodesis. So what is arthrodesis? Other name for arthrodesis is spinal fusion. So surgical stabilization of a joint through bone fusion, described by approach and by interspace or segment count. So fusion is the surgical stabilization of a joint. Okay. So whenever you want to code this spinal fusion, we need to check for the approach, whether it is anterior, posterior, posterolateral or interbody. So if you want more information about these approaches, please mention in the comment section of this video. So next, interbody technique. So fusion performed in the disc space between two vertebral bodies, often with an implanted device, maybe approached anteriorly, posteriorly or laterally. So what happens here, during the fusion process, sometimes physician will use the interbody technique, where physician will place the device in between two vertebral bodies after removing the intervertebral disc. So that is the interbody technique. Next one, interbody biomechanical device. Okay, so a synthetic case, mesh or methyl methacrylate construct placed in the disc space or vertebral body to defect to support arthrodesis or maintain disc height. Okay, so during the biomechanical device or interbody fusion, physician will place the PEEK, okay, polyethyl methyl methacrylate construct in between the two vertebral bodies to compensate the removed intervertebral disc. Next we have instrumentation, or usually we will call it as spinal instrumentation. So hardware placed to immobilize the spine while fusion matures. So described as segmental or non-segmental and as posterior or anterior. Okay. If you want to code it as segmental fixation, so these are the keywords: pedicle screws and rods spanning multiple levels. So these are the keywords for segmental instrumentation. Next we have allograft. So bone graft material harvested from a donor, reported as morselized or structural. So we have two types of allograft in spine surgery. So those are morselized and structural. Next, autograft. So bone graft material harvested from the patient, reported as local, same incision, or harvested through a separate skin or facial incision, and as morselized or structural. So in allograft, patient will take graft from the donor. In the autograft, patient will take uh, graft from the patient. So both allograft and autograft contains two types, morcellized or structural bone grafts. Okay, if you want to code autograft, you need to check where patient is taking this graft or what is the harvesting site. Whether it is local means near to the operative area, or harvested through a separate skin or facial incision, or far away from the operated area. So based on that we have CPT code. Next, tethering, vertebral body tethering. Okay, growth modulating technique using flexible cord to correct scoliosis in skeletally immature patients without fusion. Okay. Next, we will see few words related to vertebral body augmentation. So these most of the procedure related to vertebral body. So vertebroplasty. So percutaneous injection of cement into fractured vertebral body for stabilization performed under imaging guidance. Okay, so basically vertebroplasty, patient will inject the cement into the fractured vertebral body for stabilization. So most of the time patient will perform vertebroplasty under imaging guidance. Next we have kyphoplasty, percutaneous vertebral augmentation. Okay, so percutaneous procedure that creates a cavity in the vertebral body before cement injection with the goal of restoring vertebral height. Okay, so basically in vertebroplasty, patient will directly inject the cement into the fractured vertebra. In the kyphoplasty, patient will first create the what do you call cavity, and in that cavity patient will place the injection. So that is the difference between vertebroplasty and kyphoplasty. Okay. Next we will see few cranial procedures. So craniotomy. So surgical opening of the skull with a bone flap that is replaced at the end of the procedure, which is called as craniotomy. So craniectomy, surgical removal of a portion of the skull where the bone is not immediately replaced, often used decompressively. Okay. So here in craniotomy, surgical opening the skull with a bone flap that is replaced at the end of the procedure. But in craniectomy, patient will not replace this flap. Okay. Cranioplasty, surgical repair of a skull defects with or without graft material. Next, burr hole, a small circular opening drilled in the skull used for biopsy, drainage, ventricular access, or as part of craniotomy. So here you need to remember, during the burr hole creation, if the patient performs craniotomy, you don't need to code separately. Okay. Next, trephine, a larger circular skull opening created with cylindrical saw. So basically this is the device to create the circular skull opening. So twist drill hole, a very small skull opening created with a manual or powered twist drill, typically for catheter or monitor placement. Duroplasty, repair or expansion of the dura with or without graft. Decompressive craniectomy, so removal of portion of the skull with or without duroplasty to relieve elevated intracranial pressure. So wherever you see decompression or decompressive, you need to understand patient will reduce the pressure on inside the brain or on the nerves. Next we will see few visualization and access related stuff here. So open, a spinal procedure performed with continuous direct visualization through surgical opening. So open procedures are presumed unless otherwise specified. Okay. Next, endoscopy, a spinal procedure performed with continuous direct visualization through an endoscope. Next, percutaneous, so an image guided procedure performed with indirect visualization without a device that allows visualization through a surgical incision. So this is very important if you want to code these procedures. First you need to check the approach, whether it is open, endoscopic or percutaneous. Okay. In open procedure it is simple. So patient will create the incision and he will open the surgical site. Okay. So in endoscopic, direct visualization. In percutaneous, most of the time patient will use the imaging guidance like CT or fluoroscopy. So percutaneous means indirect visualization. So direct visualization, light based visualization of the surgical bleed performed by IR with surgical loops, microscopes or endoscope. This is the direct visualization. indirect image guided visualization, not light based. So direct visualization is light based visualization. Re-exploration or revision. So return to same surgical bed as prior procedure. Most of the time we have this re-exploration procedure in the spinal fusion. Next, third section, surgical approaches. First we will see spinal surgical approaches. Anterior. So anterior means approach from the front through the abdomen, chest or neck to access the vertebral bodies and disc. Posterior. Approach from the back through the spinous process and lamina to access the canal and posterior elements. Posterolateral. So back and side approach using fusion to access both the posterior elements and lateral aspect of the vertebra. Lateral extracavitary. A flank approach to thoracic or lumbar spine that avoids entering the chest or abdominal cavity. Okay. Next, transpedicular. An approach that drills through the pedicule to reach the vertebral body or far lateral disc space, typically for far lateral disc herniations. Okay. Transpacet lateral extraforaminal. Variants of the far lateral approach used to reach disc material located outside the foramen. So far lateral means outside the foramen. So costovertebral. So thoracic approach passing alongside the rib head to reach the vertebra, often for far lateral thoracic disc herniation. Transoral. An approach to the upper cervical spine and clivus through the mouth. Presacral. An approach to the L5 to S1 disc space through the presacral facial plane with imaging guidance. Okay. So before the sacrum, presacral. Next we will see skull base related approaches. So craniofacial approach, combined facial and cranial exposure to the anterior cranial fossa, often involving rhinotomy, ethmoidectomy, spinotomy with or without maxillectomy and orbital exenteration. So orbitocranial approach, exposure to the anterior or middle cranial fossa through the orbit and cranium with suborbital grid osteotomy. Infratemporal approach or pre or post auricular. So approach beneath the temple, in front of or behind the ear to reach the middle cranial fossa, parapharyngeal space or infratemporal fossa. Transtemporal approach through the temporal bone. Trans means through the basically. Temporal bone mastoid to reach the posterior cranial fossa, jugular foramen or middle line skull base. So next, translabyrinthine approach. A temporal approach passing through the labyrinth of the inner ear, classically used for vestibular schwannoma excision. Transcochlear approach. A more extensive transtemporal approach passing through the cochlea with labyrinthectomy. So basically what is important here is, whenever, for example, if the patient wants to perform a labyrinthectomy, okay, so you don't need to worry about this approach. You need to approach whenever you want to code fusion procedures basically. Transcondylar approach. Approach to the posterior cranial fossa, jugular foramen or midline skull base that includes occipital condylectomy and may include section of upper cervical vertebrae. Okay. Transpectoral approach or petrosal approach. Approach to the petrous bone. Skull basic coding structure. So approach procedure. The exposure of the skull base lesion categorized by anatomical fossa and the structure dissected to reach the lesion. Definitive procedure. So biopsy, excision, treatment of skull base lesion once exposed, categorized by anatomical fossa and by extradural versus intradural location. Repair reconstruction. So closure of the surgical defect reported separately when extensive grafting, cranioplasty or flaps are required. So in this section we will see conditions and diagnosis. Spinal stenosis, central, narrowing of the central spinal canal, typically compressing the thecal sac and cauda equina or spinal cord. So that is the central spinal stenosis. Spinal stenosis, lateral recess. So narrowing of the lateral portion of the canal, compressing the transferring nerve root before it enters the foramen. So what is important here? Central spinal stenosis is compressing the thecal sac, cauda equina or spinal cord. So lateral recess like compressing the nerve root before it enters the foramen. Foramenal stenosis, narrowing of the neural foramen, compressing the exiting nerve root. So this is lateral recess is before enters the foramen. Okay. Foraminal stenosis is exiting nerve root. Herniated nucleus pulposus. Usually in the documentation we will see it as HMP or herniated disc. Okay. Displacement of disc material beyond the normal margin of the disc space, often compressing a nerve root or the thecal sac. Okay. So basically displacement of disc material. Paralateral disc herniation. So disc material that has migrated outside the foramen, requiring a transpedicular, transfasciate or extraforaminal approach. Next, spondylosis. So spondylosis, other name is osteoarthritis of the spine. So other than spine, we will call it as osteoarthritis. In the spine, we will call it as spondylosis. See here, degenerative changes of the spine, including disc desiccation, osteophytes, and facet arthropathy. Spondylolysis, a defect or stress fracture of the pars intercalaris, most common at L5. Spondylolisthesis. So basically, listhesis means slippage of the vertebra. Is called as spondylolisthesis. Next, radiculopathy. Okay, most of the time you will see this radiculopathy during nerve root decompressions. So pain, weakness or sensory changes in the distribution of specific nerve root caused by compression of irritation. Okay. Synovial cyst, a fluid-filled outpouching from a degenerative facet joint that can compress neural elements within the canal. So, and also, if anyone looking for medical coding jobs in UAE, USA and India, please join in our WhatsApp group. Group link is in the description of this video. So, and also our trainings include same-day surgery training as well as SEC training. If anyone interested for these trainings, please send WhatsApp message to 707-526-3939. And also, while reading this or while watching this thing, if you have any difficulty, please mention in the comment section of this video. Okay. Next, post-laminectomy syndrome. Persistent pain following spine surgery, sometimes with associated spinal instability or deformity. Annular defect. So, a tear or weakness in the annulus fibrosus, often associated with disc herniation. Okay. So, next we will see few terminology related to spinal deformity. Scoliosis, a lateral curvature of the spine, may be congenital, idiopathic, neuromuscular and degenerative. Next, kyphosis, an exaggerated forward curvature of the upper spine. Okay, so this is upper spine problem basically. Lordosis, the normal inward curvature of the cervical and lumbar spine. Loss of lumbar lordosis termed flat back. Next, junctional deformity, abnormal alignment at the transition between two regions of the spine, often focused corrective osteotomy plan. Sagittal imbalance, loss of the normal front to back alignment of the spine, often requiring 3-column osteotomy for correction. Flexible versus fixed deformity. A flexible deformity reduces with positioning or bending. A fixed deformity does not change with flexion, extension or bending. Next, we will see few cranial pathology. Mostly in same-day surgery coding we will not code, but we will see. Intracranial hypertension. So, elevated pressure within the skull from causes such as stroke, trauma, tumor or hemorrhage may require decompressive craniectomy. Okay. So, pseudomotor cerebri, elevated intracranial pressure without an identifiable mass lesion or hydrocephalus. Slit ventricle syndrome, a complication of CSF stunting in which the ventricles become collapsed and overdrained. Hydrocephalus, accumulation of cerebrospinal fluid within the ventricles, often treated with shunting or endoscopic third ventriculostomy. So next we will see anal caries malformation, downward displacement of cerebral tonsils through the foramen magnum, sometimes treated with suboccipital craniectomy and cervical laminectomy. And cephalocele, a congenital protrusion of brain tissue through defect in the skull. Hematoma, a collection of blood classified by location related to the dura and brain. Cerebrospinal fluidic CSF leak, leakage of CSF through dural defects, sometimes presenting as rhinorrhea or otorrhea after skull base surgery or trauma. Next, we will see few tumors and lesions during neurosurgery coding. So, vestibular schwannoma, aquastic neuroma. Other name for vestibular schwannoma is aquastic neuroma. So a benign tumor arising from the vestibular nerve located at the cerebellopontine angle approached by a translabyrinthine rectosigmoid or middle fossa. Meningioma. A typically benign tumor arises from the meninges. Olfactory groove meningiomas may extend through the cerebriform plate. Pituitary adenoma. A benign tumor of the pituitary gland. Commonly approach transnasally or transsphenoidally. So basically transsphenoidally means through the sphenoid sinus. So cerebellopontine angle tumor. Enemas located at the CPA, most commonly a vestibular schwannoma or meningioma. So clival chordoma, a rare bone tumor arising from notochord remains in the clivus, often extending into multiple skull base regions. Paraganglioma, other name for paraganglioma is glomus tumor. So vascular tumor arising near the jugular foramen or carotid body, often requiring combined neurosurgical and otologic approaches. Intraspinal lesion, extradural, a mass within the spinal canal but outside the dura. For example, synovial or epidural. Intraspinal lesion, intradural extramedullary, a mass within the dura but outside the spinal cord. Okay. Intraspinal lesion, intramedullary, a mass within the substance of the spinal cord itself. So basically spine surgery is little bit complex, so you need to spend more time to read all this. Okay. If you have any difficulty to understand these terms, please mention in the comment section of this video so that I can create a few more videos related to this topic. Okay, and also if you like this session after watching, so please click on like button so that YouTube will share this video to other people also, or other coders who are in need of or who wants to learn neurosurgery coding. So basically, frankly speaking, if you learn all this terminology, so you will be master in neurosurgery coding. Okay, and also if you are also planning to join as a neurosurgery coder, or if you are planning to attend any interviews related to same day surgery coding, so you will get good opportunity. Okay, so these are very important for your interviews also basically. So in interviews they will ask this only, they will not ask more than this. So if you want to clear any thing, so you can learn this. Okay, so thank you guys. So thanks for watching Fast Coder 21. As I have discussed, you need to mention so your doubts in the comment section of this video. Okay, so that I can create few more videos soon. So that is the thing I want to explain to you. So if you have any doubt, please mention in the comment section of this video, and if whatever it is topic. Okay, so whatever it is, please mention in the comment section of this video. So I will create one more video related to all your confusions, all your doubts. Okay, so that thing I want to tell about this one. Okay, so that's all for today guys. So as I have discussed, so neurosurgery is very complex, but if you learn or if you watch this complete video and also share this video to your friends also, okay, so they will be beneficial in order to learn this one. Okay, neurosurgery. So thank you guys. Thanks for watching this video. All the best for your neurosurgery coding.